Good afternoon, Penn Staters. Where else would you rather be than a Zoom full of Penn Staters? I'm Paul Clifford, CEO of the Penn State Alumni Association. I'd like to welcome everybody to today's virtual speaker session titled Insomnia from Childhood Through Young Adulthood, Risk Factors, Racial Inequalities, and Health Consequences. Live closed captions are available. You can access them by clicking the closed caption button at the bottom of your Zoom video window and then clicking Show Subtitle. You may also customize your caption view by clicking the Stream to Text link in the chat. And we're live streaming today's presentation, which will be archived and available on our website. Today's guest is Dr. Julio Fernandez-Mendoza. He is the Edward O. Bixler Professor of Psychiatry and Behavioral Health and Professor of Public Health Sciences and Neurobehavior Sciences at Penn State. He's an Associate Vice Chair for Faculty Development and Research Scholarship and the Director of the Behavioral Sleep Medicine Program. Dr. Julio Fernandez-Mendoza is a scientist-clinician trained in psychobiology and clinical psychology and board certified in BSM. His research aims to help and understand the development of aspects of disturbed, insufficient, and misaligned sleep and their association with heart, brain, and mental health. He also examines the effect of cognitive behavioral versus pharmacological sleep therapies, and he practices at Penn State's Health Sleep Research and Treatment Center, where he trains the next generation of BSM providers. Ladies and gentlemen, please welcome Dr. Julio Fernandez-Mendoza to today's virtual speaker session.
Thank you so much, Paul, for the introduction, and thank you all Penn Staters for having me today. I'm going to actually be presenting data from Penn State. You will hear a lot about the Penn State child cohort during my presentation. I'm going to focus today on this pediatric research that we're doing from a sleep standpoint, where we're collecting data up to young adulthood. And the focus is going to be insomnia. And I will talk a little bit about what is insomnia, but very briefly, to show you how insomnia develops over time, what happens with kids with insomnia, and what are the risk factors and inequalities as well as health outcomes that we encounter. So just to start, I'm going to give you a sense of how I'm going to organize this talk. First, I'm going to talk about nosology. And what is nosology? It means diagnostic manuals, classification of disorders. Then we're going to talk about polysomnography. Polysomnography is a term that you may have heard if you have had a sleep study, and it's equivalent to a sleep study. So I want to talk about how we classify insomnia from a clinical standpoint as of today, how we diagnose it, and then also how we measure objectively sleep and what are the implications for that. And then I will structure my talk in terms of findings pertaining to childhood per se, then the transition to adolescence, and what we have newly found in the past couple of years in the transition to young adulthood. And of course, I will conclude with some remarks. So insomnia, what is insomnia? Insomnia truly is difficulty initiating and or maintaining a sleep, as well as early morning awakening. Early morning awakening means that you wake up earlier than desired and you're unable to go back to sleep. This particular symptom actually is much more present in adults, particularly middle-aged and older adults. In children and adolescents, difficulty initiating sleep is the number one, and difficulty maintaining sleep is the second one. So these are the main symptoms of insomnia. But obviously, we do not diagnose insomnia to anyone who has difficulty initiating or maintaining sleep. These difficulties need to happen at least 3 times a week, and they have to be associated with daytime functioning problems, such as that those insomnia symptoms lead to fatigue or concentration problems or any sort of impact. So once you have all those symptoms together, then you can diagnose insomnia. So what has happened with insomnia diagnosis over the years? What you have here is a table that has all the proposed diagnoses of insomnia back in 1997 with the International Classification of Sleep Disorders, back in 2005, and the current one that we're using that was revised in 2014. You do not have to be an expert to clearly see that something important that has happened in the past decades, and is that from a ton of insomnia diagnoses, we've moved to very few. And this is not because the field actually improved in its ability to diagnose insomnia. It is mainly because with the diagnosis based on ICSD-2 in 2005, it was studied that all these diagnoses did not have good reliability and validity. And what does that mean? It meant that clinicians did not agree well when providing diagnosis to people with the same symptoms. So in other words, that all these diagnoses lacked sufficient validity in terms of clinical care. Now, when it comes to youth, when it comes to pediatric and adolescent populations, the diagnoses that were most commonly used back then were behavioral insomnia of childhood, which is a type of insomnia related to limit setting and sleep onset association. So this means kids who have bedtime resistance, children who have the need to have the presence of an adult to be able to sleep. Then the other most common diagnosis in children and adolescents back then in 2005 was inadequate sleep hygiene, which means having poor sleep behaviors. Idiopathic insomnia actually was a diagnosis that was given to adults that reported childhood onset insomnia. But as I said, these diagnoses lack a lot of reliability and validity. And another diagnosis that was typically used in youth was psychophysiological insomnia, which was shared with adults. Now, as I said, the problem was that these diagnoses did not show good validity. And we ended up in 2014 with almost basically one ring to rule them all. Why? Because chronic insomnia disorder is actually the most common diagnosis that will encompass all of them. In fact, short-term insomnia disorder is more similar to what used to be called adjustment insomnia or acute insomnia previously. That means an insomnia disorder that has lasted for less than 3 months. Chronic when it's more than 3 months. And as you can imagine, most adults, for sure, but even adolescents and children, they show up in the clinic when the problem has lasted at least more than 3 months. Think about a parent or caregiver is going to wait to see if those symptoms go away or not. And by the way, you've noticed that I'm using the word symptoms all the time. And it's because even chronic insomnia disorder as of today, short-term or any other type of insomnia disorder, the diagnoses still are based on symptoms reported by the person or the caregiver, but not on objective sleep data, which is polysomnography, the sleep studies. And why do I want to remark this? Well, I want to remark a little bit about polysomnography because we get this question a lot. Like, if I have a sleep complaint, I will have a sleep study. And the current paradigm is that no, polysomnography, coming to the lab to do a sleep study, is not recommended for the routine assessment of insomnia in youth, unless you have, as a clinician, a suspicion that there may be something else. For example, if the parent, caregiver, or the person reports very loud snoring with difficulty breathing, well, maybe sleep apnea needs to be ruled out. But as it comes to insomnia per se, it is not recommended. And why is that? Well, it is because of this. Complaints of difficulty initiating or maintaining sleep are actually associated with very small or even non-significant differences in things such as sleep latency, which is the time to fall asleep, wake after sleep onset, which is how much time the person remains awake in the middle of the night, or total sleep time, which is the amount of sleep that the person gets. When measured with PSE, in other words, there is very small differences between good sleepers and those who report insomnia complaints. So this led to this paradigm. However, today, as part of telling you about the evolution of childhood insomnia into young adulthood, I am also going to touch on an alternative paradigm that we've developed in Hershey. That is that polysomnography, sleep studies, objective measures of sleep may actually be helpful in identifying individual differences among youth. In other words, phenotypes or subtypes of insomnia based on whether you have insomnia and you sleep normally. In youth would be typically more than 7.5 hours physiologically in the lab, or short, less than 7.5 hours. And these phenotypes or subtypes may have differences that are very important for clinical care. So let's start with childhood, right? The Penn State child cohort was established by the person that I'm very proud of holding an endowment under his name, which is Edward O. Bixler. Ed Bixler is a pioneer in the sleep field. If you want to read about him, you can find a paper written by myself, Dr. Calhoun, on journal Sleep Advances. It's public domain, and it's called Ed Bixler from the Apollo Project to sleep epidemiology. So Ed Bixler, in the last path of his career, became a sleep epidemiologist, and he established the Penn State adult cohort back in the 90s, and in the early 2000s, he established the Penn State child cohort. And this was a random sample, meaning these were not necessarily clinical patients or randomly or volunteers. These were randomly selected children using the school system in Dauphin County. And these kids were randomly selected through the schools to come into the lab. 700 5 to 12 years old with a median age of 9 came into the lab, and they had all sorts of procedures, of course, including an in-lab sleep study. And when we have examined a lot of questions with this child cohort, a lot. If you put either Ed Bixler's or Susan Calhoun's or my name in PubMed, you will find a lot of papers on multiple topics. But of course, insomnia was one of the main ones. And one of the first papers we published on insomnia symptoms in the Penn State child cohort was on the prevalence of the insomnia symptoms and the association with gender, with sex, and age. And what was the main finding that we encountered? Well, we did find that when it comes to the age range of 5 to 12, there are significant sex pubertal disparities. Females at the age of 11 to 12 have a much higher prevalence or frequency of insomnia symptoms. Their parents are more likely to report, yes, my girl, who is 11 to 12, has difficulty initiating or maintaining sleep than males. And you can see that before age 11 to 12, there are no sex differences. Males and females actually have a very similar prevalence of insomnia symptoms frequency. And of course, all of you know that nothing important happens to females at age 11, 12. Females mature earlier than males. Women mature earlier, both from a brain standpoint as well as secondary sexual characteristics. So something is going on with these females at age 11 to 12. Back in the day, many decades ago, it was assumed in a kind of like sexist way that was because girls are more likely to be anxious and depressed. Well, in this particular study, we showed that that could not explain the difference. There were no differences based on sex for anxiety and depression in these girls. What these girls were showing already was that their polysomnography, when they came to the lab, they indeed were physiologically sleeping worse than males. So this means that also insomnia symptoms, they start to develop earlier in females associated with objective sleep disturbance, a more severe insomnia. Well, by the way, when we move forward with this data, we thought, well, so what happens with those who indeed have a more severe form of insomnia? Well, we did find that indeed stress hormone levels are different if you're a child who has insomnia and can sleep 7.5 hours or more in the lab versus if you're a child who has insomnia and sleeps less than 7.5 hours. This is hormone levels, cortisol levels upon awakening in the lab and before going to bed. And you can see that these kids who with insomnia and short sleep had significantly higher cortisol levels. They were already physiologically more stressed. And also we did find behavioral profiles between these two subgroups that were different. Those with insomnia and short sleep that had higher stress hormone levels, they also had more anxiety and depression. While it was those children with insomnia, but that could sleep at least 7.5 hours in the lab, those kids were more likely to have oppositional behaviors, explosiveness, that means like having outburst or inattention, or more variability in their mood or school problems. So we had an internalizing problems profile versus an externalizing behaviors profile. And obviously our question was, and what happens to these kids as they become adolescents? And that's the focus of the research that I've been paying the most attention. So about 7.5 years later, we follow the Penn State child cohort again at age 12 to 23. Don't be scared by these 23. A minority of them were older than 19. Remember, the WHO definition of adolescence is age 10 to 19. Only 10% of them were 20, 21, 22, or 23. So 90% of these kids were between the age of 20 to 19. Median age was 16, and 421 of the 700 came back as adolescents. So you can see that these two time points are clearly two different developmental stages. Any of us can relate to that. We were very different people at the age of 9 or 16. So why adolescence is so important from a sleep standpoint? Well, because adolescence is associated with brain maturation. During adolescence, what happens is that synaptic density decreases. And what is the synaptic density? That is the synapses is the way that our brain cells communicate between each other. So when we're children, all those brain cells are tightly tied to each other there. And then with brain maturation, our brain becomes more efficient. So it needs to communicate less between the cells because it has established better networks. Also, there is increased myelination, and that means that our brain is actually maturing very well. And as I said, brain maturation happens earlier in females, and it is indexed by the sleeping brain. So when we do a PSG study of polysomnography, we measure brain waves, right? So we can see different things such as slow waves. Slow waves are a marker of how deeply we are asleep. And slow waves actually change a lot with adolescence. You can see here that in childhood, and this is based on our own data, at around age 7.4, slow wave activity, this is how deeply the brain is maximal. So the slow waves are really high. Our brain is full of them. And then what happens, look at that, after age 9, around 10, the adolescents, these slow waves lose power during sleep. So we lose slow wave activity or slow waves as our brain matures. So I want to say this because the data that I'm going to show you now in terms of insomnia needs to be taken into account in terms of this transitional period for insomnia. Underlying is all this process in which the sleeping brain and the brain is maturing and changing a lot. So what happens to insomnia? And that is exactly what we looked at. We look at the natural history of insomnia symptoms as these children transition to adolescence. But the first thing that we looked at is what happened to them. So out of these 421, only 30% of those who had insomnia symptoms in childhood fully remitted. This means that both the child and the parent said, yes, we have no insomnia symptoms anymore. So the adolescent self-reported, or the parent also confirmed, yes, my kid does not have insomnia symptoms anymore. Only 30% of them. 56% of them persisted with insomnia symptoms. So they continue to complain about difficulty initiating or maintaining sleep. That's more than 50%. And what happened to those who did not have insomnia symptoms in childhood? Well, 31% of them newly developed insomnia symptoms in adolescence. So we have, if you want, childhood onset insomnia symptoms that persist into adolescence and new onset insomnia symptoms in adolescence. So that was the first finding. And the second question was, and how is this affected by different factors? So who is at greater risk of each of these natural history trajectories? Well, when we look at full remission, and here the question is, so who is more likely or who is less likely to fully remit? What we found is that Black African American were 7 times less likely to fully remit in the transition to adolescence. So Black African American children were 7 times less likely to fully remit in the transition to adolescence. And non-Hispanic whites that came from households of low socioeconomic status were 2.5 times less likely to fully remit. So that you can understand what those figures mean, look at this plot. This is split into non-Hispanic white in white, racial ethnic minorities in general in black, and you can see that only 10% of Black African Americans mostly fully remitted in the transition to adolescence, regardless of socioeconomic status. And you can see here that non-Hispanic whites of low SES, only 25% fully remitted in the transition to adolescence, while non-Hispanic white children that came from higher SES households, 40% of them had fully remitted. So very important racial ethnic disparities that start earlier in childhood. And what other factors did we look at? Well, what we call biobehavioral risk factors. And what we found is children, and remember the color coding is on purpose. So this means childhood, this means adolescence. Children who had already been identified to have an internalizing disorder, this is anxiety or depression as a diagnosis, were 6 times less likely to fully remit. And children who had a musculoskeletal disorder, this typically means pain, were 5 times less likely to fully remit. Then adolescents, those who develop or had or were obese in adolescence, 14 times less likely to fully remit. So remaining or developing obesity in adolescence, huge risk factor for your childhood insomnia symptoms to not go away. That's what the data means. What about persistence? Persistence means childhood onset insomnia symptoms that remain when you become an adolescent. So here you can see that indeed females actually have 2.5 times greater chances of remaining with persistent insomnia symptoms in the transition to adolescence. So in other words, being a woman actually puts you at risk of having childhood onset persistent insomnia symptoms. Same thing for Black African American, almost 4 times more likely to persist, and non-Hispanic whites of low SES again, 3 times more likely to persist. How does these racial ethnic disparities look like? This is what we found. And there is a very interesting finding. You can see that the persistence rate among those of low SES is very similar, regardless of whether you're non-Hispanic white or a racial ethnic minority, about 60%. Now, even in high socioeconomic status households, racial ethnic minorities had a very high persistence rate, almost 90%. How do we interpret this data? Well, we know that these disparities are related to inequalities in the way you're treated. So this is not something biological. This means that psychosocial factors are playing a role even in high SES environments. And you're not protected. SES is not protecting you from having had childhood insomnia symptoms and remaining with them in adolescence. In fact, your environment is contributing to those insomnia symptoms. What were risk factors for the persistence of these childhood insomnia symptoms? Again, having had an internalizing disorder, anxiety or depression in childhood, 6 times more likely to persist in the transition to adolescence. And then a lot of adolescent-related risk factors. Obesity, again, high predictor of persistent insomnia symptoms, having any other mental health disorder that was not internalizing, and here you can include ADHD, anything like that, and tobacco use. Early tobacco use in adolescence, 7 times more likely that then your childhood, remember, childhood onset insomnia symptoms will persist. So it does not allow you to leave them to go away. What about new onset? What about those who did not have childhood insomnia symptoms, but now they report them as adolescents? Well, from a demographic standpoint, once again, females were 2 times more likely to develop insomnia symptoms in adolescence, and those individuals from low socioeconomic status are the ones that are newly developing insomnia symptoms in adolescence. Why is this important? Because what this is talking about is that when it comes to new onset of insomnia symptoms in adolescence, socioeconomic status is the main driver, and that racial ethnic disparities show up earlier in life when it comes to persistent childhood insomnia symptoms. So we need to target these inequalities early in life to stop them from persisting. When it comes to new onset, we need to address SES inequalities. That's what is going to help us address inequalities in sleep later on in adolescence. When it comes to other risk factors, once again, anxiety and depression is a very strong risk factor, independent of all these other ones, for the development of adolescent insomnia symptoms. So in other words, children who had an internalizing disorder and were free at that point of insomnia symptoms were about 5 times more likely to newly develop them later on. And then also having any other mental health disorder in adolescence, having a neurological disorder in adolescence, and in this case I can tell you it's mostly migraines, headaches, and then an evening circadian preference. What does that mean? Having an evening circadian preference means being an evening type, an owl, becoming a night owl in adolescence was a risk factor for starting to complain of insomnia symptoms, particularly difficulty initiating sleep. So you can see that we have identified very well both demographic and biobehavioral factors that put children at risk of either persisting with childhood insomnia symptoms or newly developing them in adolescence. So what was our next question? Our next question was, and what happens with these youth as they become young adults? Well, that's exactly what we're doing as of today. We are actively recruiting the Penn State child cohort in the lab, like literally as of today. We have surveyed 525 of them, and we have examined in the lab already 295. We believe with the impact of that COVID had on any type of human research like this, we will be able to get 310 in the lab by June 2025. So these kids are now clearly young adults. When they come to the lab, they are 20 to 33 right now years old. Actually, they should be updated. They're 20 to 33 years old. They now come sometimes even pregnant, and we examined them when they were 5 years old. It's absolutely nuts. I have the honor of being the principal investigator now of the Penn State child cohort for this third visit. And the first thing we looked at, obviously, was the trajectories of insomnia symptoms. Because insomnia symptoms are by self-report, we were able to use the first round of surveys when we had about 500 of these kids, now young adults, report data. So I'm going to show you data a little bit differently because we have 3 time points. So what you're going to see in the following graphs are trajectories, and I'm going to help you with those. So the first question would be, what happened with those children who had insomnia symptoms as you guys watch them transition from adolescence to young adulthood? Well, 43% of those with insomnia symptoms had persistent problems throughout their life, even up to age 25. So this is 43% of them had persistent childhood onset insomnia symptoms throughout. 27% of them fully remitted by adolescence, and they remained remitted. Great outcome. They had the problem and it went away in yellow. 11% of them had persisted into adolescence, but then eventually remitted in young adulthood. Good. A little bit later because they had persistent symptoms into adolescence, but then eventually remitted. And then there is this 18.6% of children that wax and wane. It went away, now it came back. And you may wonder, and what happened to those who did not have insomnia symptoms? Well, remember, we had the incident cases in adolescence, right? Well, indeed, 15% of them develop insomnia symptoms in adolescence and continue to have them in the transition to young adulthood. 16% also wax and wane. They develop them and now they don't have them. But look at this, 21% of them that did not have insomnia at either childhood or adolescence eventually develop insomnia symptoms. So you can see how insomnia symptoms can be developed in a high proportion of people at different developmental stages: adolescence, childhood, adolescence, and newly in young adulthood. And then obviously 48% of those with normal sleep actually remain absent of insomnia symptoms throughout. That's a value that is very well accepted. So very important data. Actually, I remember getting a lot of emails from both sleep clinicians and pediatricians saying this data is fantastic because it's what we see in the clinic. And now it was confirming their clinical experience with population-based data. You may wonder, and what happened with those racial ethnic disparities? Well, one of my prior students worked on this data, and she's now at NIH. And the bottom line of this very busy graph is the following. Look at to the right. This is a persistent trajectory. Remember that for both those with insomnia symptoms and without insomnia symptoms, we define like those who persisted and wax and wane. So you could put those plots together, and we have people who basically never had insomnia symptoms, that 48%, but then those who eventually remitted, those who wax and wane, regardless of whether they started with yes or no with insomnia symptoms in childhood, those who eventually develop insomnia symptoms either in adolescence or young adulthood, and then here we have the persistent cases. So if you focus on this group, I don't need to put p-values, significance, or tell you anything to see that clearly Black African Americans, Hispanic and Latinos, and any other ethnicity that is not non-Hispanic white, look at that, they are overrepresented in the persistent insomnia trajectory. Only about less than 20% of those in a persistent insomnia, childhood onset insomnia trajectory are non-Hispanic white, while all these other groups are overrepresented at rates of above 30 to 40%. So these disparities that can be addressed early in time will not go away. They will not go away as the person becomes a young adult. Your environment is not going to protect you. In fact, very likely, your environment is going to worsen the problem. And what happened also with another predictor, that is the short and normal sleep that you were telling me about earlier on, Dr. Mendoza? Well, what we examined was that now as these guys were young adults, they did not only now report insomnia symptoms, but as young adults, they were able to tell us, oh yeah, I have an insomnia disorder. I've been diagnosed or treated for insomnia. Now it became a disorder, and it's not just the symptoms of insomnia, of difficulty initiated or maintaining sleep. So what we found is that indeed insomnia symptoms with normal sleep duration were not associated with developing an insomnia disorder. and it was children, and particularly adolescents, who had insomnia symptoms, who already reported the symptoms and slept short in the lab, that were about 5 times more likely to end up in young adulthood to say, yes, I have a full-blown disorder now. So adolescence is a critical time point to prevent the evolution of insomnia symptoms into a clinical condition. And these subgroups, this insomnia with normal sleep duration and insomnia with short sleep duration, is a type of phenotyping that we've proposed at Penn State. Literally, not other places. Penn State was the pioneer in proposing that indeed recuperating objective sleep measures of sleep duration to phenotype, to subtype insomnia can be useful. And I presented to you how today, apart from the risk factors for youth with insomnia, these measures can also be applied. And these phenotypes, we've described them very well. They are very different in terms of biological factors, in terms of behavioral profiles, and of course, they do share similarities when it comes to mental health. But overall, these are two very different phenotypes with very different trajectories and prognosis or risk. So, in conclusion, what does all this mean? Well, from a developmental trajectories standpoint, in terms of what happens to children as they mature in life, what we found, what we've contributed to science is that childhood onset insomnia symptoms that persist in the transition to adolescence and adolescent onset insomnia symptoms are highly likely to persist into young adulthood. This is very important because back in the day, it was believed that insomnia symptoms in childhood or adolescence were developmental, that they will go away, like sleep terrors or sleepwalking, right? That the child matures and then they don't show up anymore. No, insomnia symptoms are a persistent issue. And youth, particularly adolescents, with the insomnia with short sleep subtype, are highly likely to evolve into a full-blown insomnia disorder when they become young adults. Now, from a social determinants and biobehavioral factors, our data clearly is showing that racial, ethnic, and socioeconomic disparities are involved in the persistence or incidence of insomnia symptoms in youth, that sex disparities are pronounced with or after puberty and are associated with an adolescent onset insomnia symptoms. So women also need to be a focus of our attention, and women's health should be paying attention to sleep more closely. And above and beyond these racial, ethnic, economic, and sex disparities is still, if you've been diagnosed with an internalizing disorder, anxiety or depression, neurological disorder, particularly headache or migraines, and you're developing a strong evening type, chronotype, those are risk factors that you will develop adolescent onset insomnia symptoms. And just to conclude, I hope that I presented today a little bit of data to convince some people that objective measures of sleep and not just the self-report may be clinically useful, particularly in adolescence, and which is a critical period for an adverse prognosis of this more severe phenotype. Obviously, all the data that I presented you would be impossible without the support of funding agencies. And in the case of my own projects, NHLBI and NIMH have been instrumental in funding the progress with this Penn State child cohort and literally keeping it alive, as well as other funding agencies that have supported me throughout my career. And this is the work of a lot of people. I always like to still acknowledge Ed Bixler, although he's now a professor emeritus and he's happily retired because of his seminal contribution to our lab. And a lot of the faculty that we work together from multiple departments and a lot of trainees and technologies that make all this data many times actually happen. So with that, I'm happy to take questions, and I thank you very much for your attention. All right.
All right, excellent. So the questions that I have are actually, I think, straddle the research that you've presented. So let's start at the beginning. You talked about racial inequalities, right? What do you think are some of the causes that lead to insomnia in Blacks and Hispanics and non-whites, essentially?
So that's a great question. I always say that I regret either having included measures, specific measures in the current follow-up, or basically not having had them in the childhood. And that is related to good measures of perceived racial discrimination, perceived sex-based, gender-based discrimination to as well as many other factors that have to do with the structural issues as well as contextual issues. And why am I pointing towards those social factors, right? Those mechanisms, as you're saying. Why is it that you have insomnia symptoms? Well, because your level of stress is much higher. And here, where can we imply that from? The socioeconomic status data. If you saw the likelihood of fully remitting. So basically the good outcome, right? You want childhood insomnia symptoms to go away over time. If you notice, only 10% of racial ethnic minorities, only 10% fully remitted in the transition to adolescence. And that was regardless of whether they came from a low SES household, basically a household with parents that are struggling economically in a poor neighborhood with a lot of broken windows, right? And many contextual situations that all of us can understand. Well, that will impact the sleep. Also, kids that came from wealthy environments, being racial and belonging to a racial ethnic community that is considered a minority, also had a poor outcome. So why is that? Because even communities of higher SES can be and are racist. And that is what I think is the main mechanism. These children are subjected to inequalities in the way they are being treated, how they relate to others, how the school system, many stressors that are added for not for being a minority. Now, have we measured that specifically? No, and I regret it. But the fact that we did not find that it was just purely an SES-based issue, which we'll all understand. Okay, low SES, then that would lead less healthcare access, whatever. There has to be a structural societal issue. And this is what we think that is going on. Now, am I supporting that on others' research? Of course. There is a ton of research showing that both contextual environmental factors play a role in racial ethnic minorities. Of course, there's factors such as the conditions of your neighborhood, as well as your own even household, your living room, whether you sleep alone or you sleep with three more people, right? But also societal level ones. There's a ton of research coming from multiple groups in the country showing how perceived racial discrimination, unfair treatment, and so forth and so on plays a role in these sleep health inequalities.
So we have a question coming in about if there's any research on adopted children and insomnia symptoms.
Beautiful. Yes, there is. I am not expert on the topic, but a very good colleague, Dr. Alfano, check her out. She has a great website. She does amazing research in adoption as well as in foster care. That's her specialty, but both adopted children and foster care. And basically the bottom line of her research is yes, the prevalence of insomnia symptoms and many other sleep problems is much, much higher in especially in foster care children because of the level of stress that they have to go through, and also in cases of adoption. And there again, Paul, as you were saying, there is always mechanisms that it can explain that, and is the level of added stress. in your adoption process. Attachment plays a huge role, etc. So yes, that is a beautiful question, and I will encourage you to look into Dr. Alfano's research, Alfanono, sorry.
Yeah, and we just dropped that link into the chat. So you should be able to see that, and we will also include that in the email that goes out afterwards, so you can take a look at Dr. Alfano's research there. So,
Yeah.
what would you say? So you've diagnosed it, right? You've seen the trends in insomnia, but what are some of the long-term kind of mental health, physical health, right, brain health impacts of insomnia, especially
Yeah.
on adolescents?
Correct. So usually in childhood, we see the underlying mechanisms of risk, and then typically in adolescence is where we start to have to see issues. So data that I did not present today, but we have it and it's published. We found that in adolescence, insomnia is associated with increase in inflammation, systemic inflammation. So for the general public, what does that mean? It doesn't mean that you're literally inflamed. You're not like a balloon. It means that your body is generating systemic inflammation, which means that you're having an immune response, that you are under a situation in which your body is highly stressed and you're actually starting to generate the molecules that are involved in heart disease, diabetes, or many other medical problems. Now, did all adolescents who reported insomnia have this high inflammation? No. It was those who reported insomnia symptoms and slept short in the lab. Okay, so this is why it's important the research we're doing, because it is on one side, sure, preoccupying, because it's saying, well, guess what? Yes, insomnia is more serious than we thought, but we also tell people, but not everyone who is complaining of difficulty sleeping is in the bucket of those who may develop, as you said, heart or brain problems related to insomnia. It is a subset, okay? So that's number one: inflammation, high blood pressure, and some glucose, increasing glucose, which is related to diabetes. And then in terms of insomnia and mental health problems, the association is very clear. And as I showed today, is even since childhood. We know that insomnia, anxiety, and depression are tightly related to each other. But one thing that you may have seen today is that sometimes, and many times, insomnia can precede these type of disorders. So we know nowadays that particularly in adolescence, if you develop insomnia, the likelihood that you will end up being diagnosed with a mental health issue, be it anxiety, depression, is very high. So insomnia actually, I would say, is an early sign, preventable early sign of future development of mental health. We can target sleep to improve heart, brain, and mental health of our society.
Excellent. What, if any, correlation with, you think of kids today, and oftentimes their leisure activity is in front of a screen, right? They have an iPad or a cell phone that they are on, which, if that's their leisure activity, it leads to maybe less outdoor activity, less exercise. What have you found about amount of screen time or lack of exercise that also leads to insomnia?
So actually, we've done more research in terms of physical activity. Screen time is something that we have not measured systematically. We have a great colleague here at Penn State, Anne-Marie Chang, who is up in main campus at University Park. Really good colleague, and she has done a lot of research on screen time and screen intensity, light, the blue light spectrum on sleep and all that. And the bottom line is, yes, with the increase in use of devices that emit bright light, it is true that kids and even adults end up delaying their sleep timing. That is because this light has an stimulating effect on our brain. And when I say stimulating, it's not that it creates alertness, it's that it literally inhibits melatonin production. So melatonin is our endogenous, our normal hormone we produce before going to sleep. So if you inhibit the secretion, right, what can happen is that our brain thinks that it's still daylight and it doesn't need to go to sleep. So it has, we call it a circadian effect. Circa dies around a day, 24 hours basically has an effect on the timing of sleep. And this is very well established, I would say. Now, the issue with the screen time is not as straightforward as, yeah, well, kids are using it, that's bad for you. In many cases, if you use screens properly, they are not as bad as we typically think. It is a matter of the wrong timing of using them, and when they align with your sleep timing or not. Now, you mentioned something important. It's part of leisure activity. In other words, that many of behaviors end up interfering with sleep. And that is where we blame, not so much from an insomnia standpoint, but from a insufficient sleep standpoint. So what is going on nowadays with too early school start times and too late activities is that it is true that there has been a generational change where adolescents are expected to mature, premature, socially mature, and at the same time go to school at 7 a.m. in the morning, wake up at 6 to catch the bus, and go and do all these multiple activities plus homework that has become 3 times the load than before until whenever time. So any people who listens to this and has an adolescent at home will totally agree with this. Their day ends up being enormous. So how do we want to prioritize the sleep? So we need a culture change in that sense. We need to go back to understanding that sleep is not just resting. Sleep is a fundamental, essential human need. And I would say even right, because it's pure biology. We need to sleep and we need to sleep well. We need to go back to allowing adolescents to have a proper sleep routine. So sleep is not just 9 hours in bed. Good sleep means, sure, maybe 9 hours in bed for an adolescent plus 2 hours of appropriate leisure, which means also being at home, relaxed, engaged, going to bed, right? So there is so many things that also we need to rethink about whether you want your offspring to be involved in 4 sports plus homework plus schooling. Maybe we have a problem there. When do you want them to sleep?
So we've talked about causes, we've talked about your research. We have time for one more question. And so essentially my question is, what kind of interventions are there or treatments to help children, adolescents, young adults deal with insomnia? I remember when I was a kid, my mom used to tell me to count sheep, right? I think I think that might work on a one-night basis, but when it's health related, when it's medical and brain related, I'd imagine that there are pharmaceutical and maybe even non-pharmaceutical treatments available.
Correct. And in fact, the treatment of choice as of today, and this is not just my opinion, this is guideline recommended, behavioral therapies are the first line treatment for insomnia. And actually, this applies to both youth, children, adolescents, as well as young adults, middle-aged adults, and older adults. The therapies themselves may change, they may tweak slightly differently, depending on the presenting cases. But when it comes to insomnia, the first-line treatment is behavioral therapy. What people are usually recognize as CBT, cognitive behavioral therapy. Well, CBT for insomnia, for example, in adults, first line guideline recommended treatment. When it comes to peds, to children, to young children, typically in young children, insomnia is going to be related to those limit setting issues and sleep onset association that I was talking, meaning bedtime resistance and needing an adult to sleep with them, then in that case, also behavioral therapy is the first line treatment, not medication. And then if behavioral treatment fails because the insomnia of that child is not truly related to that type of behavioral issue, then maybe sometimes a type of medication, low dose medication may include it. In adolescence, same thing. Most of us will choose CBTI, adapted from adults to adolescents, as the first line treatment, so behavioral treatment of insomnia for adolescents. In their case, however, as I mentioned before, their brain is maturing, they are becoming more evening types, and I show you today how being a strong evening person in adolescence risk factor for insomnia. In their case, we need to rule out that they are not having a problem with the timing of sleep. So these, again, there may be many people listening that go, oh yeah, that's exactly what happens to my kid. Adolescents who cannot fall asleep earlier than, let's say, 2 a.m. and it's very difficult to wake them up in the morning. And actually they miss school and they end up waking up at 11. On weekends, they may sleep until 12 and so forth. That is a different type of problem. That is a circadian rhythm disorder. And that we treat with light therapy and differently. So in adolescence, we need to be a little bit more scrutinize that. And then again, if none of that, if behavioral treatment does not work, then maybe medication will be implemented. Now, Paul, you may say, but as far as I know, most people that I know with insomnia get a med. They get a sleep medication. Why are you saying all this about CBT and behavioral treatment? One of the problems we have in the country is that despite knowing that you can achieve more than 50% of remission of insomnia with a behavioral therapy that is very well validated, we have a shortage of providers, training, and access. So that is the reason why still a lot of people are put on sleep meds, because many primary care providers, for example, they look around and they're like, yeah, but where do I have the sleep expert? Where do I have the Dr. Fernandez-Mendoza to work with me and treat my patients and his team? Well, there is very few of us that can provide CBTI in adults or that can provide CBT or BTIs in children and adolescents. So that's the reason why.
Well, and I also think that our culture is always looking for the quick fix, right? I mean, having to make an appointment and meet with the provider, right? That takes time versus just give me the medication, right?
Correct. That's true. That's true. There's a portion of the population that have a preference towards, as you call it, like a quick fix. Yeah.
Right.
And it sometimes it happens with peds too. Parents who rather prefer, going to a pharmacy and buying an over-the-counter melatonin and giving their kids very high dose melatonin that, by the way, we don't know in the future what would be the health outcomes of that. And it's not recommended at all to do that.
Absolutely. Well, we would like to thank you. Fascinating topic. Thank you for joining us today and for sharing it with the Penn Staters that have joined us. We are grateful that you have done this presentation, and thank you very much. And we also want to thank everybody who has tuned in today. Thank you for your support of the Penn State Alumni Association. If you're a member of the Alumni Association, we're so grateful for your support. If you're not yet a member, what are you waiting for? Go to our website at alumni.psu.edu, and you too can become a member of the world's largest alumni association. Thank you for all you do for the university, for the glory, and for the future. We are
Penn State.